In the previous video, we have seen a lot of basics and details on oxygenation and its governing laws that helps in your understanding about the high altitude sickness and all these things. In this particular video, we are going to principally concentrate on the ventilation and the perfusion. So first, let us move on to the ventilation. As far as ventilation is concerned, ventilation is very, very important for bringing in oxygen into your alveoli and back into the capillaries. And it's also very, very important and quintessential to take the carbon dioxide out of your body by eliminating through the atmosphere. I believe that the most important purpose of ventilation is eliminating carbon dioxide than taking in oxygen, because the carbon dioxide is the one, if it accumulates in hypoventilation states, it's going to prevent the further entry of oxygen into the alveoli and causes hypoxia and hypoxemia. So you can understand the body ventilates to eliminate carbon dioxide. I believe that's the most important function of this ventilation process. Ventilation means you have to understand a very important terminology called a minute ventilation. So what do you mean by minute ventilation? It is a product of tidal volume multiplied by respiratory rate. So you all know what is the normal tidal volume. It's approximately 500 ml according to many physiology textbooks. But always please tell it is 6 to 8 ml per kilogram of ideal body weight. This is the normal tidal volume according to the body weight. Suppose if your tidal volume is low, we call this patient is having reduced depth of respiration, or we call it as hypopnea. The tidal volume is high, we call these patients are having increased depth of respiration and we call it as hyperpnea. Similarly, your normal respiratory rate is somewhere from 12 to 20 per minute. And any patient, this is for an adult, not for children. Any patient who's having reduced respiratory rate, less than 12 per minute, we call them as having bradypnea. Any patient who's having increased rate of respiration, that is more than 20 per minute, is said to have tachypnea. Then finally, coming to the minute ventilation, normal is approximately 6 to 8 liters per minute, depending on the tidal volume and the respiratory rate. If you have a low minute ventilation, we are going to tell that this patient is suffering from a hypoventilation. And if you have an increased minute ventilation, we are going to tell that this patient is having a hyperventilation. Clear? So which means you can take the causes of hypoventilation might be either a hypopnea or either a bradypnea. Which means whenever you tell the term hypoventilation, you can add the suffix alveolar hypoventilation. Means it can be due to two causes, either due to reduced respiratory rate or it may be due to reduced tidal volume. These patients who are going to have reduced respiratory rate are the patients who are not willing to breathe, which means this patient won't breathe. And these patients who are having reduced tidal volume are these patients who can't breathe. What do you mean by won't breathe and can't breathe? Because whenever they have a reduced respiratory rate, which means it is likely to be central causes. Examples of central causes being your brainstem injury, tonsillar herniation, raised ICP, cerebral edema, brainstem stroke, Pontine hemorrhage, sedation poisoning like benzodiazepine poisoning, or it could be opioid overdose. Lot of causes. Central, they won't breathe, not willing to breathe. Whenever you have a reduced tidal volume means this patient is having a diaphragmatic and neuromuscular weakness. So that's why I told, because of the weakness, they can't breathe. Which means this can be again be due to two reasons. One, it could be a proper neuromuscular weakness. Best example being a Guillain-Barré syndrome in acute state, or it could be amyotrophic lateral sclerosis, or other motor neuron diseases, acute flaccid paralysis in polio, or a patient who's having a neuromuscular blocker toxicity. Lot of conditions you can tell. Or it could be a patient who's going for fatigue and exhaustion because of faster breathing especially during acute situations where there is too much dyspnea. They keep breathing. They suffer for breath, and after some time they fatigue, and their chest muscles will go for weakness, and they die out of type 2 respiratory failure. So please do remember, whenever there is an alveolar hyperventilation, there is an increased chance of death from type 2 respiratory failure because of carbon dioxide accumulation. Here you are going to have a carbon dioxide accumulation in the body, and that will result in hypoxemia. Please do note why carbon dioxide accumulation is a dangerous one, because your PaO2, this is alveolar oxygen. The formula is 713 multiplied by FiO2 minus PaCO2 by 0.8, which means your carbon dioxide accumulates in the body, your alveolar oxygen reduces according to the alveolar gas equation. If the PaO2 reduces, automatically your P small aO2 also will reduce, but they typically tend to have a normal A gradient, because here the problem is not the oxygen diffusion. Here the problem is your accumulation of carbon dioxide that prevents the entry of oxygen into the alveoli. So very simple concept, but very powerful one. So this is the reason why you're going to get problems during hypoventilation in a patient who's having hypoventilation. So the next concept that you have to know is something called an alveolar ventilation. What do you mean by alveolar ventilation? Alveolar ventilation, amount of gas that is getting in and out in the alveoli per minute. So alveolar ventilation can be given by the formula tidal volume minus your physiological dead space, because we are eliminating the alveoli, those are not ventilating, as well as the anatomical dead space. So multiplied by respiratory rate. So now you can ask me, how can you find out this physiological dead space? We have an equation called Bohr equation, which might be your exam question. So what is your Bohr equation? It tells you your physiological dead space is equal to tidal volume multiplied by partial pressure of arterial carbon dioxide minus partial pressure of expired carbon dioxide divided by partial pressure of arterial carbon dioxide again. Which means I can rewrite this formula as tidal volume multiplied by 1 minus partial pressure of expired carbon dioxide by partial pressure of arterial carbon dioxide. Both are correct. So this is the equation that tells you the physiological dead space. So now you know that physiological dead space is a sum of anatomical dead space plus alveolar dead space. Now you have found out the physiological dead space through Bohr equation. But how can you find out this anatomical dead space? Anatomical dead space can be found out either by a routine formula called 1/3 of tidal volume, or your physiology textbooks will give approximately 150 ml. Or if you want to find out accurately, you have a method called Fowler's method, which you have discussed in the PFT section. This is called the Fowler's method, otherwise referred to as something called a single breath. That word single is very important. That's a single breath nitrogen washout technique. So this is how you find out the anatomical dead space. The moment you know the anatomical dead space, you also know the alveolar dead space by a very simple formula. Is equal to physiological dead space minus anatomical dead space. Very easy and again very powerful. Okay. So with this, we are finishing off the ventilation as well. Then we can move on to the perfusion. Clear? Perfusion is again a very important concept of the lung. And lung maintains its own perfusion. And one very, very important concept that you have to understand in lung perfusion is the hypoxic pulmonary vasoconstriction, which we already have a good idea, which we have discussed in oxygenation concepts itself. On the other hand, let us see some of the facts. So what is a normal pulmonary blood flow? It is same as that of the cardiac output, that is approximately 5 liters per minute. So where is the distribution of blood flow? Blood flow is maximum blood flow happens in the base of the lungs. The base of the lungs is the one that's going to have highest perfusion. Number 2. Number 3, your mean pulmonary artery pressure is approximately 10 to 14 millimeters of mercury. When it exceeds 25, we call it as pulmonary hypertension. Then you have pulmonary artery systolic pressure. The normal is 18 to 25 millimeters of mercury. If it exceeds 30 to 40, we call it as pulmonary hypertension again. Then you have pulmonary capillary wedge pressure, which we have discussed about this in ARDS in a very detailed way, which is actually an indirect measure of a left atrial pressure, which is equal to approximately 5 to 8 millimeters of mercury. This is a very important point. The pulmonary capillary wedge pressure is going to indirectly correlate with the left atrial pressure, or you can call this pulmonary capillary wedge pressure as an indirect measurement of the left atrial pressure. So then you have another important concept called hypoxic pulmonary vasoconstriction, otherwise referred to as Euler-Liljestrand mechanism. So we have already know about this hypoxic pulmonary vasoconstriction, where if the alveoli is hypoxic, means the blood flow will find a serious resistance in that area, which means the blood flow will not happen because of vasoconstriction, because the ventilation in that alveoli is going to decrease. This is a very important process because they should not go and connect with the pulmonary veins on the other side, right? So suppose if the blood is coming from the pulmonary artery, let us put in blue, it should not go and mix with the pulmonary veins that will be forming on the other side, which is carrying the oxygenated blood. Suppose if this blood, because of the poor ventilation of the alveoli, is going directly and mixing with the pulmonary veins, means you're going to result in a shunt formation, which is a physiological right side to left side shunt, where the deoxygenated blood is directly mixing with the oxygenated blood, and this will result in severe hypoxemia. So to avoid that, the lungs go for this hypoxic pulmonary vasoconstriction, where the blood will be diverted to the alveoli that are normally functioning, which means they form this oxygenated blood on the other side. So they prevent the shunt formation, which means this blood also will be diverted towards the normally functioning alveoli. So this blood is going to be diverted to the normally functioning alveoli. So that is the reason why they provide high resistance at this area, that is to divert the blood. And this is to avoid the VQ mismatch and shunt formation. That's why they do that. And it all works only to physiological limits. You cannot tell that this is the principle that can change everything in the lung. No, to an extent it can work. Otherwise it will not work, such as breakdown can happen in high altitude pulmonary edema cases. Clear? And what forms this hypoxic pulmonary vasoconstriction, for that matters? There are something called, if we take the pulmonary vessel, there is something called a hypoxia sensitive potassium channels. You know, the natural movement of the potassium in these channels is outward efflux. That's what the potassium channel does. And these are hypoxia sensitive. You can imagine these channels as ATP sensitive potassium channels in your beta cells. Clear? ATP sensitive potassium channels in your beta cells. Like that, these channels are hypoxia sensitive potassium channels, where if you have a hypoxia, these channels will be blocked. Once these channels are blocked, the potassium tends to accumulate. That creates a depolarization wave inside the cell, which is going to bring in calcium by depolarization and activation of this calcium channel. This calcium is going to cause contraction of the smooth muscles, resulting in vasoconstriction. Clear? Very simple fact. And there are a lot of conditions that inhibit the hypoxic pulmonary vasoconstriction. What are they? Very important to understand. First one is the alkalosis, and second one is elevated alveolar pressure. Typically you can call PEEP in mechanical ventilation, positive end expiratory pressure. Next, in patients who are going for high frequency ventilation. Next, in patients who are receiving endothelial vasodilators like nitric oxide or prostacyclin analogs, PGI2, nitrous oxide and prostacyclin. Or in patients who are receiving calcium channel blockers, CCBs, typically nifedipine. Nifedipine, that's why it's also used for treating pulmonary artery hypertension and high altitude pulmonary edema, because they inhibit the hypoxic pulmonary vasoconstriction. Alpha-1 blockers like prazosin. Then you can have beta-2 stimulation like salbutamol, Then if the patient is having increased cardiac output or increased left atrial pressures, some few substances like atrial natriuretic peptide, substance P, and calcitonin, gene-related peptide called as CGRP. These are the substances that are going to inhibit the hypoxic pulmonary vasoconstriction. Clear? Each and everything is important. In that, the most important will be the PEEP, calcium channel blockers, alpha-1 blockers, then elevated left atrial pressures, ANP. So these are the important things which have been already asked in exams. Okay. Then let us understand the VQ mechanism, ventilation and perfusion mechanism. The model what we are going to use is what we refer to as the vascular waterfall model, which typically divides the lung into certain zones called zones of West. Zones of West. And these zones of West are generally understood. This vascular waterfall and zones of West are generally understood in erect posture, either supine or standing position. Either sitting or standing position. Only in erect posture, the zones of West are classically described. And West is actually a very, very big pulmonary physiologist. He has its own book, West Pulmonary Physiology. It's one of the very, very good books to read for pulmonary physiology. And one of my favorite books, in fact. So he's the one who gave this zones into we will see in the next image. So what are the zones we are dividing and how these things are going to work. So this is an image that shows the zones of West. So where the lung is divided into 3 different zones called zone 1, zone 2 and zone 3. Remember, we are talking about erect posture in sitting or standing position. So where, and one important thing if you want to know, let me put an arrow. If I ask you where is the ventilation maximum, where is the perfusion maximum? If I ask you the condition where is the perfusion maximum, immediately everyone will answer zone 3 is the place where the perfusion is going to be maximum. There's no doubt about that. The perfusion is maximum at the zone 3 only, because by gravity the blood flows to the base more and more. Fine. If I ask you the ventilation, where is it maximum? If I ask you the ventilation, where is it maximum? Everyone will answer it is zone 1. But actually it is not the case. The ventilation is typically maximum once again in zone 3. This is the place where your ventilation is going to be maximum as well. Which means both the ventilation as well as the perfusion is going to increase in this particular order. Zone 1 is going to have the less ventilation and less perfusion, zone 2 moderate, and zone 3 maximum perfusion and maximum ventilation. How is it possible? So let us take an alveoli. So you have an alveoli here. So let us assume this is zone 1 alveoli. I mean, you can understand the fact that air ascends up. So how is it possible to have a zone 1 to have less ventilation? It's not like that. Let us assume this is zone 1. You know that air ascends up and the zone 1 will be filled with air all the time. And this is a zone 3 alveoli, because there are 2 things that are acting upon. One is the blood that is flowing into the zone 3. At the same time, the weight of the lung itself is acting on zone 3 only. So the zone 3 alveoli tends to be very, very small. And zone 1 alveoli, no weight happening. The blood vessels are also not compressing. At the same time, air is also ascending up. So zone 1 is going to be very big. All right. So zone 3 is like this, zone 1 is like this. So if you ask me during inspiration what will happen to zone 3, zone 1? So zone 1 alveoli will expand. Fine. And during expiration, same position. Inspiration, expiration, inspiration, expiration. But on the contrary, what is happening to zone 3 alveoli? Inspiration, expiration, inspiration, expiration. You can see now comparing together. Do you think which is having more ventilation? Zone 3, which means zone 3 is the one that collapses more during expiration and expands more during inspiration, which means the movement of air in and out of the alveoli is more in zone 3. And that's what we're going to call as ventilation. Clear? So that's why I'm telling you ventilation is also more and perfusion is also more in zone 3. Clear? But the VQ ratios are different. If you ask me the VQ ratio in zone 1, the ventilation is less, but the perfusion is too less in zone 3, which making the VQ ratio of approximately 3 here. It is different. The VQ ratio is actually more in zone 1. In zone 3, if you take the VQ ratio, the ventilation is very high here. Similarly, but the perfusion is too high here, making the VQ ratio 0.6. Which means the VQ ratio is low, but the ventilation and perfusion both are high in zone 3 only. It is somewhere in between. But if they ask you the entire lungs VQ ratio, it's approximately 0.8. At the same time, the ideal VQ ratio, if they ask you, it must be 1. Clear? But naturally, the entire lungs VQ ratio is approximately 0.8. Fine? Okay. So this is also the reason why here the ventilation perfusion ratio is very high, 3, which means relatively more air with less perfusion, which means the immunity reaches very less there. That's why TB thrives here. That's the reason. Similarly, the VQ ratio is very less, means the ventilation as well as perfusion is very important. That's why clinically speaking, the most important lobe, I'll be telling the lower lobe only. Lower zones only. Why? Because this is the one that's having maximum ventilation, maximum perfusion, and maximum gas exchange, and every function is going to be high in the zone 3 only. That's why this area is physiologically very important. That is also one reason why in TB patients you don't see them distressed till the last stage. Or in a patient with apical TB or apical emphysema, apical bulla, they don't suffer that much. But if you get a basal disease like ILD or pneumonia or an IPF, you're going to suffer early. Because this is a very important zone, and you compromise that, you end up with dyspnea and breathlessness much faster. Clear? And what are the equations that you're going to see? It's a very simple equation that you wanted to see. In the zone 1, you can see the alveolar pressure will be too high because I told you the alveolus is too distended with blood, and obviously your pulmonary artery pressure will be a little bit lesser compared to the alveolar pressure because the perfusion itself is less, followed by the pulmonary venous pressure. Venous pressure is always less than the alveolar pressure. And in zone 2, you can see that let us finish off the zone 3 and come. In the zone 3, if you see, it's too high perfusion, where the pulmonary artery pressure is the maximum here, followed by the venous pressure, followed by the alveolar pressure. It's too high. The blood vessels flow is too high, so which means the arterial and venous pressure are more than the alveolar pressure. But you can see here it's somewhere in between. So here the arterial pressure is more, but it's not, next is not the venous pressure. Next is the alveolar pressure, and finally it's the venous pressure. You can see the alveolar pressure keeps varying. So it's initially it is at the top, then in the middle, then it comes to the least in the zone 3. So that's why alveoli is like this in zone 1, like this in zone 2, and like this in zone 3. And the pulmonary artery pressure will keep on increasing as it moves towards the bottom. Clear? So which means if you see the blood flow, here the blood flow is nil. Why? Because the alveoli is the biggest and it's more than your pulmonary arterial and pulmonary venous pressure. Because of that, there will be no blood flow happening, which means that's what happens. Here, since the arterial and venous pressures are continuously high, you will result in continuous blood flow throughout the cycle. But here you can see the arterial pressure is more than the alveolar pressure, is more than the venous pressure, which means alveolar pressure is somewhere between the artery and the vein. So depending on the phase of the respiration, you will get intermittent blood flow. That's why this region is also referred to as waterfall zone. Clear? So now let us see in a tabular column form. You have this zone 1, you have this zone 2, and you have this zone 3. So which area of the lung you belong to? This belongs to apex, middle zone, and to the base of the lung. Equation wise, if you see here the pulmonary alveolar pressure is more than the pulmonary artery pressure, more than the pulmonary venous pressure. But here the pulmonary artery pressure will be more than the pulmonary venous pressure will be more than the alveolar pressure. But here somewhere in between, where the pulmonary artery pressure will be more than the alveolar pressure, more than the venous pressure. You can see the alveolar pressure is the maximum here, intermediate here, least here. And this is how you remember. Clear? So obviously the pulmonary blood flow, as I told you, it's going to be continuous because the pulmonary blood flow is going to be continuous in zone 3. You can see very clearly the arterial and venous pressures are very, very high compared to the alveolar pressures. Here it's going to be 0 by definition because the alveolar pressure is always more than the vascular pressures, but here it is somewhere in between, so which means there is going to be intermittent blood flow. Then what about the vessels? Pulmonary blood vessels, we're talking about the blood vessels. They are distended and open all the time. Here they are collapsed all the time in the apex, but in the zone 2, they will be in the waterfall zone. They will open and they will close depending on the phase of expiration or inspiration. Then alveolar size. Here the maximum, here is going to be the least alveolar size, and here intermediate again. Then gas exchange and ventilation. Here it's the maximum, here is the minimum, that is the least, and here is somewhere intermediate. We discussed these facts already, so I've just compiled in a tabular column form. That's all, nothing else. Clear? And the fourth kind of pressure we have not discussed. Fourth kind is there, that's called, suppose if you have a basal zone of atelectatic areas. Suppose you're having atelectatic zone, basal atelectatic zone like this. So what will happen? So once again, here there will be another force that is trying to compress on the airways. That is the interstitial pressure. So we are dealing with a special zone called atelectatic zone, so which is called as zone 4 in general. So here there will be another force called interstitial force, that is called pulmonary interstitial force. That's also will be acting on the alveoli and your pulmonary blood vessels. So here once again the blood flow will decrease and they will reach a little bit of lower level and they won't be having full blood flow. Clear? So they won't be having this full blood flow like what you think. Clear? So you can see the blood flow is going to decline sharply here. So if you ask what will be the equation in this zone 4, you can clearly tell here the pulmonary artery pressure will be more than or equal to interstitial pressure, which will be more than or equal to pulmonary venous pressure, which will be more than the alveolar pressure. Which means once again, your alveolar pressure has become the least, like what is commonly seen in the base of the lung. At the same time, your interstitial pressure becomes more than the pulmonary venous pressure, which means once again it will reduce the blood flow like what you see in the zone 2. Because in zone 2, your pulmonary venous pressure is superseded by the alveolar pressure. But here, the pulmonary venous pressure is superseded by the interstitial pressure. So that is the reason the blood flow decreases. You can see here, and it becomes somewhat similar to that of zone 2. Clear? So this is what is going to happen. So this you have to remember, exam may ask about this zone 4, which is nothing but the atelectatic or collapsed zone, where the interstitial pressure will take over, and that will also exert its effects, and that also will result in sometimes a reduced blood flow. Okay, then let us see some of the special effects of this perfusion. Special effects of this perfusion principle. So we have to see some important special effects, like what will happen in supine position, what will happen when the patient is hypovolemic, and what will happen when you are doing an exercise, and what will happen when you are doing a swimming under breath holding. Swimming or a breath holding. Clear? So let us see the first principle. What will happen when you are in supine position? Let us see the image. There will be conversion of the areas. In supine position, what's going to happen is you're going to convert the zone 1 typically to zone 2, and the original zone 2 will be converted to zone 3, which is clearly evident by this image. Clear? You can see this zone 1. Now it has become zone 2 here. and this zone 2, now it has become predominantly zone 3, which is a very important thing, which means it is going to more, ventilation and more perfusion, which means you are resulting in better VQ matching and reduced VQ mismatching. Because zone 1 is the one thing that has the highest VQ mismatch. So by converting zone 1 to zone 2 and zone 2 to zone 3, you're having a better VQ matching and reduced VQ mismatching. Then what will happen if the patient is hypovolemic? If the patient is hypovolemic, typically your pulmonary artery pressures and pulmonary venous pressures are going to decline dramatically because of hypoperfusion. So which means many of the areas your pulmonary alveolar pressure will increase relatively because the venous and arterial pressures are dropping, which means you're trying to produce increased amount of zone 1. What you're trying to do is you're converting zone 2 to zone 1 here, which means you're trying to produce more and more zone 1 because alveolar pressure now takes over relatively because the pulmonary artery pressures are dropping. And you're converting zone 3 to zone 2 typically. In the sense, you are producing more of zone 1. That's what's happening when you are in a hypovolemic patient. Suppose if you are swimming or breath holding. Suppose you are swimming or if you are breath holding. What's going to happen? If I breath hold, typically swimming is also a method of breath holding only. What happens during swimming and breath holding? Actually, I'm distending the alveoli, which means I'm going to increase the alveolar pressures during inspiration. Clear? So if I increase the alveolar pressures, this is an absolute increase, not a relative increase like in hypovolemic patients. This is an absolute increase in alveolar pressures. If I'm absolutely increasing the alveolar pressures, I'm going to produce more of zone 1 again. Same effect will happen. I'll be trying to convert the zone 3 to zone 2 and zone 2 to zone 1, which means I'm increasing the zone 1. So which means whenever I increase the V1, zone 1 areas, my VQ mismatching will increase. That's why many people will get extremely breathless when they swim or when they breath hold. Clear? Because you are producing more and more VQ mismatch. Similarly, the swimming and breath holding also will increase the VQ mismatch because I'm trying to produce more of zone 1. Similarly, what will happen in exercise is I'm trying to increase zone 3 in exercise because exercise will typically increase the pulmonary blood flow because of hyperdynamic circulation. Once I increase the pulmonary blood flow, the pulmonary artery and the pulmonary venous pressures will start increasing, which is the feature of the lower zones of the lung. So it might take over your alveolar pressures so that you will be converting zone 1 to zone 2 and probably a zone 2 to zone 3, which means whenever your pulmonary artery and pulmonary venous pressures are increasing because of exercise increasing pulmonary blood flow, you might actually result in better VQ match, which means you will have increased VQ matching, which means you are reducing the VQ mismatching. Clear? Exercise will tend to produce a VQ ratio of 1 usually, many times. So it also tends to open the apical vessels which are normally collapsed. So a lot of things are there. So these are some of the special things that you have to understand. So whenever you have a type 1 respiratory failure, I'm giving a hint because this is being discussed in detail in respiratory failure topic. This is called hypoxemic respiratory failure. Basically, we divide into 3 things. One is called a VQ mismatch, and second one a diffusion limitation, and third one you can put under shunt formation. This VQ mismatch means VQ can be more than 1 or VQ can be less than 1. You have some characteristic example. Similarly, shunt formation means VQ is equal to 0, where directly your right-sided blood is shunted to the left side without getting oxygenated. That's what we call VQ is equal to 0. VQ equal to 0 means your ventilation is equal to 0, which means directly your blood is reaching the right side to left side, which means when ventilation is equal to 0, perfusion is happening, VQ must be equal to 0, and which means it's equivalent to shunting of blood from right side to left side, which means the deoxygenated blood is shunted towards the oxygenated blood, resulting in severe hypoxemia. Diffusion limitation, irrespective of the VQ, only two conditions you have to know. We already discussed in the last chapter, that is emphysema and ILD. Classic examples. These are some of the examples of respiratory failure, type 1 respiratory failure, and we have discussed these types of respiratory failure in detail in the respiratory failure chapter, which you have a separate topic on it, so don't worry about it. We have given in extreme details there. Finally, what are the important other data about the pulmonary circulation? Number one is the pulmonary complaints. Pulmonary complaints. So normally, complaints means how much blood the pulmonary circulation holds. Normally it is approximately 500 ml. But during cardiac failure, it can hold up to 1 liter also. Beyond this 1 liter, they cannot hold, and they will cause leakage of the water into the capillaries, from the capillaries into the alveoli, resulting in pulmonary edema and congestion. So in heart failure, it can hold up to 1 liter. This is a maximum pulmonary capacitance. And this is a normal pulmonary capacitance where the pulmonary vasculature holds a blood of approximately 500 ml. You know, veins are capacitance vessels, which again we have discussed in the resistance section, and complaints and resistance section in the next chapter. Now, what are the substances that are modified in the pulmonary circulation? So there are certain substances which are modified in the pulmonary circulation. There are certain substances which are removed completely from the circulation. There are certain substances that are removed partially from the circulation when they're going into the lungs. And there are certain substances which levels are unaffected by moving through the pulmonary vasculature. So what are the substances that are modified in the pulmonary vasculature? The most important, the first one will be the angiotensin 2, and the last one also will be the angiotensin 2, because your angiotensin 2 is formed from angiotensin 1, which is converted by angiotensin converting enzyme, and this angiotensin converting enzyme is present in the pulmonary capillaries only. Very important concept. Clear? So this is the most important substance that is modified in the pulmonary vasculature by default. And what are some that are removed completely? One is serotonin. Remember, the serotonin is not removed by enzymatic degradation. Instead, it's removed by uptake, not by enzymatic degradation. This is also a question in exam. Then your leukotrienes completely removed. Prostaglandin E2 and prostaglandin F2 alpha. These are two prostaglandins that are removed completely. There are certain prostaglandins which are not affected. That also I'm going to tell. And what are some that are removed partly? One is bradykinin, almost 80% removed, and by the same enzyme, that is angiotensin converting enzyme. That's the reason why when you give an angiotensin converting enzyme inhibitor, your bradykinin levels will increase, resulting in intractable cough in some patients. Typical dry cough due to ACE inhibitors. And it can remove norepinephrine up to 30% of its original levels. Again, remember, norepinephrine is removed by uptake, not by degradation. These two are very, very important. Serotonin and norepinephrine are removed by uptake and not by degradation. Where serotonin is complete, norepinephrine is partial. Those levels are unaffected is angiotensin 2. Definitely, angiotensin 2, even though it's formed in the pulmonary vasculature, it's not going to get affected by pulmonary vasculature by any means. It's not affected. Second is the ADH, vasopressin. Third one is the histamine. And fourth one is the dopamine, no effect. And fifth one is the two prostaglandins, prostaglandin A2 and prostaglandin I2, which is also referred to as prostacyclin. Remember, prostacyclin analogs are also used in your pulmonary arterial hypertension, where there is pulmonary vasoconstriction. To relieve the pulmonary vasoconstriction, use this prostacyclins. And one of the main reasons why we use the prostacyclin analogs is because those levels of prostacyclin analogs are not altered by the pulmonary circulation because of the movement there, and that's why it's going to act more and more in the pulmonary vasculature. That's also one important applied aspect is there. Apart from that, this is the end of the ventilation and perfusion topic. It is short and sweet one. With this, we'll close it down and we'll move on to the next section, that is the mechanics of breathing, which is far more important.